Hello, how are you guys doing? Welcome back to another episode of Let's Learn PT. Today we're going to be discussing two shoulder pathologies involving the glenoid labrum. So before we go too deep into these pathologies, let's do a little bit of review of our structural anatomy. So our shoulder is made up of a ball in the humerus and a socket of the scapula, the socket being called the glenoid fossa. So essentially, that ball articulates with the socket. And the presence of a labrum, the actual structure that is compromised with these two conditions, is essential because it provides congruency for our humeral head to be able to travel within that glenoid fossa appropriately and with stability. Our shoulder is an inherently unstable joint because of the size of our humeral head in comparison to the rather small glenoid fossa. So the presence of that labrum helps us to be able to do our overhead activities with our shoulder that we're accustomed to doing at work and with sports-related activities without any pain and with stability within our shoulder joint, which is essential because our shoulder joint is one of the only joints where we don't have added stability of a large actual socket for the ball to fit into, like our hip. So essentially the two conditions we're going to cover are a slap tear and a Bankart lesion. A slap tear is a superior labrum anterior posterior. So essentially it's the top of the labrum from the front to the back. So when it tears, it often involves the insertion of the long head of the biceps that sneaks up here and partially inserts into that glenoid labrum. So when our superior anterior posterior labrum tears, oftentimes that bicep is actually detached. And it is characterized by catching, popping, locking, and instability. So essentially a lot of that catching, popping, and locking is due to when that labrum tears, it may fray over or fold over and get caught in between the humeral head and the actual glenoid fossa, causing a clicking sensation because your humeral head's trying to move in the socket like it normally does, but part of your labrum is frayed over onto it, preventing and prohibiting proper movement of that humeral head in the socket. Kind of similar to how with a meniscus, sometimes it frays over when it's torn, and it can prevent you from all the way locking out your knee. So essentially, this also is caused oftentimes by a traumatic fall on an outstretched hand, and also is characterized by weakness of overhead movements. It is often caused by volleyball players, football players, basketball players, anybody doing repetitive overhead movements. Oftentimes you can see over time they develop a slap tear. And to test for a slap tear, we do an O'Brien's test. We have the patient raise their arm up to 90 degrees flexion, internally rotate, and then the therapist provides resistance on the distal humerus. And if they feel a painful clicking deep in the shoulder, not at the AC joint, but actually deep in the shoulder, it can be indicative of a slap tear. And to confirm this testing, we do the same thing in external rotation and evaluate if there's a similar popping or if the popping is gone when externally rotated. The other pathology we're going to be covering and kind of differentiating between the two is a Bankart lesion, which is an inferior anterior portion of the labrum, right in here, inferior and anterior, and it is oftentimes characterized by an anterior dislocation. There is some force, whether it be a tackle in football or a traumatic car accident, that caused your humeral head to travel anteriorly out of the glenoid fossa and caused a tear of that labrum where that actual humeral head traveled outside of the glenoid fossa. So it is also characterized by chronic anterior instability because obviously if your labrum is torn in the anterior-inferior aspect, there is no longer that level of congruency there that's keeping your humeral head within the glenoid fossa, and you're more inept to be able to actually anteriorly dislocate both traumatically and atraumatically in the future if this labrum is not repaired. And to test the Bankart lesion, we do an apprehension relocation test. I prefer to do it in supine. You can also do it in standing or seated. You bring the patient up to 90 degrees abduction, and you have them externally rotate their shoulder, or you externally rotate their shoulder for them preferably, and you will see a look of apprehension come on their face because their glenoid labrum is not preventing their humeral head from traveling anteriorly. So their humeral head is subluxing anteriorly, and then the relocation portion is you provide a posterior glide to that humeral head and relocate it into the glenoid fossa, which will provide them some relief because the shoulder is back where it actually belongs in anatomical alignment. And that's a good way to test for a Bankart lesion and is indicative of a Bankart lesion. So these are the two shoulder pathologies I wanted to cover. We got to do a little bit of functional anatomy of the shoulder too while we're at it. So thank you guys for watching. Appreciate your viewership. Follow us at lets_learn_PT and keep up with the content. We're going to keep pumping it out for you guys. Thank you so much for watching.